Hello everyone, I'm Todorovska and I'm happy to welcome you to this webcast on scalp melanoma, the invisible killer. The head and neck area, despite accounting for only 9% of the total body surface, yet harbors 20% of all melanoma cases, and 7% are scalp melanomas. They are more common in the elderly with median age above 65 and occurs 6 times more frequently in men than in women. Data from the literature show that scalp melanomas carry high mortality rates, poor clinical outcome, lower disease-free survival, and overall worse prognosis than melanoma on other locations. This leads them to be named the invisible killer. Invisible because this is area covered with hair. In fact, in 1/4 of all scalp melanomas were found on hairy scalp, which usually meant late diagnosis and bigger breast lobe. 10-year survival rate is only 60%, and they're biologically more aggressive compared to melanomas on other locations. And which are the contributing factors for such a grim prognosis? First, the anatomy. Scalp has high blood and lymph supply. And because of the thinner dermis, Clark level in scalp melanomas is higher than in melanomas with same breast lobe or other locations. Tumor itself. Although lentigo maligna melanoma is most frequent subtype on the head and neck area, it usually occurs on the face, while superficial spreading and nodular melanoma are statistically more frequent in patients with scalp melanomas, and these are aggressive subtypes. Molecular profile of scalp melanoma carries detrimental mutations like BRAF, V60K, and NF1. Examination itself is difficult because of visually limited access when covered with hair, but bald scalp is also difficult for evaluation due to the specific anatomy features of the skin and multiple presence of other benign pigmented lesions on a chronically sun-damaged skin. It is challenging even for experienced dermatologists, and this is the most neglected part of dermoscopy screenings, but also for self-examination. Management is difficult. There is difficulty of obtaining adequate surgical margins. Challenging sentinel lymph node biopsy often falls negative due to highly complex and variable lymphatic drainage. Recurrence rate for scalp melanoma is 13% compared to only 5% for melanoma of the face, neck, and ear. Scalp melanomas is histologically heterogeneous group of tumors. Lentigo maligna, usually found on bald scalp and older age, superficial spreading melanoma on hairy scalp and younger age, desmoplastic and nodular melanoma, although rare but commonly found on the scalp. Now let's see the dermoscopy. Lentigo maligna, usually found on a bald scalp, showing atypical pseudo-network, gray circles, circle within a circle, angulated lines. While in deeper invasive lentigo maligna melanoma, even more pronounced annular granular pattern, pigmented rhomboidal structures or angulated lines, a lot of gray color and obliteration of the hair follicles. And don't be fooled by the rosettes and comedo-like openings because they are completely non-specific and can be found in any type of lesion, both benign and malignant. Superficial spreading melanoma type usually occurs on a hairy scalp and in younger individuals. You see this lesion here looking like a seborrheic keratosis clinically, but on dermoscopy, in scalp melanomas we can see mainly and more frequently regression features, atypical pigmented network, blue-white structureless, irregular pigmented blotches, and atypical vascular pattern. You can see the same structures here. Substantial regression, gray color, peppering, atypical pigment network. It is interesting that for superficial spreading melanoma type found on the back of the head or mainly in the occipital area, it resembles more melanoma on the lymph and the trunk, with typical melanoma clues, like in this case, eccentric structureless area, white shiny structures, radial lines segmentally present, and irregular non-pigmented blotches. Retroauricular area is often forgotten for applying sun protection factor and also overlooked during skin examination. You can see this example, this specific area showing regression, lines radial on segmentally present, and a lot of gray color, thick lines reticular. Fortunately, it was still in situ. Thicker melanomas on the scalp are usually showing non-specific pattern. As in this case, this is a very peculiar case. At first impression, it can be easily mistaken for a BCC. On closer look, there is no translucent background, just pink and brown and gray colored. Vessels are short, linear, but not in focus. And there are no blue-gray clouds, but blue and black structures. This was a thick nodular melanoma mimicking basal cell carcinoma, which led them to appear lower on the waiting list for surgery and eventually jeopardize patient's life. That's why any nodular fast-growing tumor found on the scalp should be sent for urgent surgery with melanoma in the differentials. In this example, mainly pink to yellow background, linear, short, irregular vessels, and a lot of white color. Also this peculiar epidermal colorate, which is in fact non-specific finding in fast-growing tumors. This tumor was more in favor of squamous cell carcinoma, but histology confirmed amelanotic nodular melanoma. Also here, large ramifying vessels and abundance of thick keratin and serohemorrhagic crust on the tumor that were removed lead to basosquamous or metatypical BCC as the primary suspect, but the final report was unfortunately amelanotic melanoma nodular type. Desmoplastic melanoma is very challenging. It can be present as a single papule or a plaque, non-pigmented, but also can be associated with lentigo maligna, showing some classical structures. But in this case, you can see just polymorphous vessels, ulceration, and some white shiny lines. There are many scalp tumors that can simulate melanoma. And let's start with even more aggressive and deadly tumor like Merkel cell carcinoma, which clinically presents as a rapidly growing red nodule in elderly. And on dermoscopy, just structureless central area with pink and white areas within, and peripheral polymorphous and poorly focused vessels. Angiosarcoma of the scalp is invasive tumor that often mimic benign, painless skin lesions like hematomas or simple hemangioma. On dermoscopy, just purple color and rainbow sign, which is non-specific and can be seen in highly vascularized tumors. Squamous cell carcinoma, poorly differentiated, is a fast-growing red bleeding tumor on the background of substantially sun-damaged skin. On dermoscopy, mostly red color and polymorphous vessels. Metastatic scalp tumors are very common. Scalp region accounts for 6.9 to 13 of all cutaneous metastases, usually appearing in late stages of internal malignancy, mainly gastrointestinal, lung, and breast cancer. This is an interesting case of a BCC imitating melanoma. A blue nodule showing monomorphous linear ramifying vessels, a lot of shiny white structures as blotches and strands instead of orthogonal lines, as in melanoma, mainly blue and white color instead of blue and black, and some translucency in the center. Fortunately, it was just cystic nodular BCC and not other way around. And this blue color was due to necrosis and hemorrhage in the cystic compartment. The most common benign lesion found on the scalp in every age is the blue nevus. And the scalp is in fact the most frequent location for blue nevus. It can be flat or elevated, but on dermoscopy showing homogeneous deep blue structureless. Sometimes, because this is an area prone to friction and repetitive trauma, we can see shiny white structures, even linear vessels. And then the most important question we must ask the patient is if there is a history of previously excised melanoma, because the main differential of a blue nevus is a melanoma metastasis. So, in conclusion, scalp melanomas behave more aggressively, have higher rates of recurrence and higher mortality as compared with melanomas on other body sites. Increasing awareness on this invisible killer is crucial for timely diagnosis and improved patient outcome. So doctors and patients should include scalp examination in their routine skin check. And do you know that in fact hairdressers have the most and the best visual of your scalp? Education of these non-medical professionals should be of great importance for timely scalp melanoma detection. Thank you for your attention, and I hope you find it useful in your daily practice.